சார்
யூடியூப்ல ஸ்ட்ரீம் பண்றியா?
ஜூம் ஸ்ட்ரீம்
ஆகுது
சார்.
ரைட்.
சார்
யூடியூப்ல ஸ்ட்ரீம் பண்றியா?
ஜூம் ஸ்ட்ரீம் ஆகுது சார்.
ரைட். போனை இது பண்ணி விட்டு அவங்கள மியூட் பண்ணி விடும். சரண்
சார்
போனை மியூட் பண்ணு.
மியூட் பண்ணுமா சார்?
போனப்பா
ஃபோன் மியூட்ல தான் சார் இருக்கு.
இத போடுப்பா.
It's 19 hours.
சார்
ஸ்கிரீன் ஷேர் பண்ணு. We'll start that. Will come to that.
Right.
நான் எல்லாருக்கும் மட்டும் ஒரு அனுப்பி தந்துறேன்.
ஷூர் சார்.
That's that.
ஸ்டார்ட் பண்ணலாம் சார். ஜஸ்ட் டு என்ஷூர் ஸ்ட்ரீம் ஆகுதா சார்? யூடியூப்ல செக் பண்ணீங்களா?
அதான் பார்த்தேன். அதான்
ரைட். ஆடிபிள்.
ரைட். ஒன்றும் பிரச்சனை எல்லாம் பார்த்தேன். நவீன் ஏற்கனவே ஒரு வேலை செக் பண்ணிருக்கேன்.
நவீன்
சரவணன் மியூட்டா கூட எல்லாத்தையும் ஒரு
வருதா சார்? ஓகே சார். சார் வெயிட்டிங்ல
இருக்கவங்க எல்லாத்தையும்
ஆமா ஆமா ஆமா
குமரேஷனோட இதை மியூட் பண்ணி விட. அவர் இது மட்டும் ஓப்பனா இருக்காரு. Welcome all. First webinar on cardiovascular. I've never done that. In this difficult times, we wanted to do something which is valuable for a lot of people who are especially working in ICU or with COVID patients. As a disclaimer, we want to say two things. One is the evidence is limited, so you want to use your common sense along with what Mr. Saravanan is saying today. The next thing you want to remember is whatever he is trying to say is based on not just evidence. There is also some amount of physiological plausibility which is involved. So I think Saravanan will also explain those things also. But I just want to give that disclaimer. Part number two, because everybody has limited experience, limited understanding of these things, we will have extended Q&A which will help everybody to understand this far better. So if you participate better, it will be a good thing. As I have never seen a COVID patient in an ICU or any U, I don't have any questions for them. But if people who are working on that, if they come up with questions, we can have a far better webinar on learning, and it will be useful for our patients. I'll just give a small introduction to Saravanan. Saravanan and I have been working for probably 8 years, I think now. So because my clinic is 6 years old, so he helped me keep start the clinic, so it should be 2 years before that. And we worked on a lot of our research together also. Again, nothing in cardio because I don't have anything to do with cardio. So this is the first time he has started his own study, a trial on COVID patients, where he is trying to see what is the effect of early rehab patient in ICU and hypoxic patients. He's been doing this for quite some time, in a sense that from the earlier wave also, we were jokingly saying that what time did you start your trial? There is no patient, right? But as a cruel joke, it came with a vengeance, right? Really with a vengeance. So he's been using whatever he's using. He will share with us, and we can throw questions on to him, and we will see how this goes, right? So over to you, Saravanan.
Right, sir.
And one more thing. If you can open your video, it will be highly useful for people who are for Saravanan who is speaking. So if it is possible, keep your videos open so that it looks like as though he's speaking to people rather than a laptop. Thank you.
Right. Thank you, sir. And yes, it all started with kind of from nowhere. You asked, why can't you just do it in it? And it didn't strike me that, yes, I have to pitch in to do something. So until that, I was also staying away from that. So yeah, I don't know whether it's for good or bad, but yeah, I do feel happy about what I'm doing. Right. So very good evening for everyone who have come here. I'm not sure if I'm going to satisfy any of your expectation in this, but I'll just try to share what I'm doing, and with some amount of background with which I know. So if you also have some similar experiences in the COVID ICU or in relation to COVID patient, please feel free to share with me, so that I think it's a mutual exchange of information rather than me telling what to do, because there is no or there is nothing like solid or concrete evidence to say that this is what has to be done. So,
sorry, Saravan, can you make me a co so that I can also invite people?
Right. So yeah,
like
I think that is constantly popping. So
right.
How to do it?
I also don't know that. So
make host. Yeah, I change host. You are host now, sir.
Okay, thank you.
Right. So I really want to understand each one of you who are here who are working in the COVID, but because of weekend and time constraint for everyone, so I'm skipping that part, and I'm straight away jumping to whatever I just want to say. So as you all know, I don't want to give a specific introduction about what is COVID, it's a RNA virus or things like that. So let's start with the how how we perceive it in the real scenario. So we all know that we screen the patient and we triage the patient. So with some rapid test or any other RT-PCR method, and then we triage them based on the severity level, either mild or low risk. They go to the isolation center, or if they are moderate to severe, they have to go to the tertiary care center, and at the end of the day, they have to be back to the community or rehab centers, which is available in certain countries, but not mostly in our place. So this is how it goes. So right from the community where they're getting tested, and the job is not over until we put them back in the community to their maximum functional level, which was there in the baseline, that is before they got infected. I think that is what we have to concentrate on. Of course, saving life is the first priority, and apart from saving life, we have to put them back in the community to the maximum or to the baseline functional status. So this is how the flow of patients in the COVID-19 care. So this is again maybe a redundant information for all of you, but still, the median incubation period is somewhere between 3 to 5 days. So anywhere after 5 days, the first onset of symptoms, if you're exposed to the virus, will happen. The common symptoms said to be fever, dry cough, and fatigueness, joint pain, muscle pain, and now many of the patients are also complaining about diarrhea, and now also conjunctivitis is one of the common manifestations. So any one, not necessarily all these symptoms has to be present, but what they have found out, fever comes in 80%, cough in 60 to 70%. So they have this probability of signs and symptoms which manifest in different people. So any one of these symptoms has to be considered like a COVID disease, unless otherwise proven other way around. So once you are here, it takes at least 7 days for us to know whether you are progressing, or you are deteriorating, or you are just being in the mild category or asymptomatic category. So from here, what probability or the statistics is telling us, dyspnea may happen in 40% of the symptomatic patients. Remember, leave out the asymptomatic patients. So in 40% of symptomatic patients, dyspnea do happen. And within this 40%, 15% may land up in severe illness, and 5% may land in critical illness. So what is this classification of severe, critical, and mild and moderate? This is again the definition from the WHO. So mild is, they fit into the definition of COVID-19, but they don't have a classical viral pneumonia features, be it X-ray or be it a CT, and they don't have hypoxia, more importantly. Moderators, they do show some signs of pneumonia like fever, cough, dyspneic, and with saturation falling. So maybe 94% or more than 90%, but not I mean, between 90 to 90, it's what considered as a moderate disease. And of course, severe is again with the classical signs of pneumonia plus respiratory rate more than 30 and SpO2 falling more than 90% in the room air is considered to be a severe disease. Again, we also have other classification based on the CT severity and the biochemical things. So those can be a surrogate measures adjunct to this, but not necessarily a primary classification system for the COVID-19 patients. So again, critical is the extreme spectrum of the COVID-19 patients one can experience. Statistically, not majority of the patient land up in critical phase. Critical phase, what they mean by it, the patient land in sepsis, or septic shock or multi-organ dysfunction, need of ECMO and mechanical ventilator with prone ventilation. So all these together, what they consider it as a critical phase of the COVID-19 patients. And we are not going to talk much about the drug, but just to give an overview of what are the drugs being given for the COVID-19. This is again a recent guideline. So for non-severe, like we said, they have categorized into 3 categories: non-severe, severe, and critical. Non-severe may be moderate to mild, and severe is, like we mentioned, less than 90. Critical requires other supporting measures. So if you see ivermectin, which is right and left prescribed, recommendation against it. So it is not being recommended. Hydroxychloroquine, recommendation against, strong recommendation, don't give. Ritonavir, again, another type of immunomodulatory drug or antiviral, recommendation against. Remdesivir, again, it is against, not to be given. Corticosteroid, like you see here, it is not recommended until the patient is in severe category. So only it is recommended or strongly recommended those who are severe to critical phase or those who are mechanically ventilated. So we are seeing being recommended, or steroid being recommended even for milder category who can maintain the saturation above 90. But still, because many people, the decision making based on so many things like CT severity, X-ray changes, which guideline is not suggesting. So the guideline is very clear with the manifestation of SpO2 and respiratory rate only who are more severe and critical clinically, not diagnostically or radiologically. You can prescribe corticosteroid. So the only drug which can be recommended, that is again during severe and critical, strong recommendation is corticosteroid, but otherwise all the drugs are not being recommended. So this is just an overview of what are the drugs available. And this is going to be a kind of, I'm not sure how comfortable you will be feeling. Many of the acute and unstable patients will not benefit from physiotherapy. So if you want to, disconnect from the Zoom, yes, yeah, you can go. But that is the reality. And of course, I'm going to talk about what scope we do have, but many patients who are unstable, what I mean by unstable is clinically unstable, and who are acute and unstable will not benefit. Maybe in the chronic patients, again, if they are unstable, our role is very, very less. So, and again, we know that in COVID-19, many patients manifest, or many patients comes with dry and non-productive cough. Again, we know that if it is going to be non-productive cough, the airway clearance it's not the major objective for us in the ICU. Okay, so we are not going to talk on mild hypoxomic more, but I'm just going to tell what we can do for mild hypoxomic. So the first and foremost thing, provide supplemental oxygen. Okay, and they start with 2 to 4 liters. And here the target is not to maintain 100, but just above 90 is enough. So never over target to maintain the saturation for 98 or 100. That's not necessary. That's what guideline says. So you can be sufficiently maintain it if it's over than 90 or 94. I think that is fine. And sometimes upright tripod position helps the patient, as you can see here. The patient is holding the hand in the, placing the hand in the knee joint, which helps to increase the work of other associated muscles in expansion of the lungs. So that might help him help the patient to reduce the respiratory rate, and more importantly, prone position. So history of prone is some 4 decades back, where it all started for ARDS patient, where they want to prone the people with ARDS. Now, in the COVID pandemic, we started to have more of anecdotal evidence initially in prescribing awake or self-prone positioning in COVID patients. So, what's the difference between before and now? Previously, the prone position is mostly passive. So the patient will be sedated and paralyzed, and it is the passive procedure with the help of 4 to 5 people to turn the patient. Now it is being recommended as a part of active management from the patient itself. And remember, you don't have to prescribe prone as a part of management for the people who are asymptomatic. There is no need for prone who are asymptomatic. It is required only for the people who are hypoxomic. You can prescribe for mild. You can do that for moderate or ARDS as well, people with ARDS, but it is not required for people who are asymptomatic or who can maintain the saturation above 96 in the room air. So I don't think they need prone push-up. So it's not necessary. So asymptomatic, all we have to do is isolate themselves, nutrition, some form of activities which is not so strenuous but not so sedentary lifestyle, but some form of sort of lighter activities and adequate nutrition and hydration. I think that is suffice for the people who are asymptomatic. So for mild hypoxemic, like I said, we can give a prone type of portion with the supplemental oxygen. You may ask, what is the role of breathing exercise and diaphragmatic, pursely breathing, and segmental expansion exercise and things like that? Again, we don't have one data to support or one data to say confidently that breathing exercise do help them in any parameter, not necessarily a respiratory rate or saturation. But we know that people in the hospital or institutional policy recommend us to do breathing exercise or incentive spirometer. So one thing because even I do that in my institution, I go, some patients, they already bought incentive spirometer, and almost for every patient we do teach diaphragmatic breathing exercise and pursely breathing exercise. So what are the ways I convince myself, even though there is no literature to support the prescription of breathing exercise in COVID-19, is okay, is there any harm in giving this intervention, or is there any benefit? So even though the benefits are quite not known at this point of time, or it is not benefit at all, but okay, let's put that aside. But is there any harm effects in giving diaphragmatic breathing? So that is the way I approach before I give any intervention, if that is not evidence, or if that is not supported enough by literature. So the harm effects of breathing exercise, when we look into it, not much, but when the work of breathing is already high, then I don't give the breathing exercise. Say, for example, if the respiratory rate is more than 30, then I don't give breathing exercise, because that again put extra burden on the patient, so I don't give it. So probably who could potentially benefit is patient who are having less than 24 or somewhere between 20 to 25 respiratory rate, where they are not so dyspneic or so laborious breathing. So we can give them as a part of relaxation exercise, rather than expecting any benefit in terms of saturation, which I'm not so sure. So because we do have some sort of literature supporting to say that breathing exercise will help the patient in relaxation. It will activate the parasympathetic chain way. So in those aspects, if the patient anxiousness level, or if it helps to calm the patient, yes, there is no harm in giving the diaphragmatic breathing exercise. So I give diaphragm, but not to the patients who are more distressed already, who are in dyspneic in so many ways. So same goes for the chest expansion or incentive spirometer, because if the patient is connected with the nasal cannula, it is fine to give the incentive spirometer. If you ask me, I don't find any difference between incentive spirometry or diaphragmatic breathing exercise. It is all just one incentive. It's just uh, it's a different form of diaphragmatic. So if you just have it, you can give it to the patient, and maybe in your absence, it will help the patients to do it, but it's not necessary. That's what I feel. But there are some institutional policies where they prescribe incentive spirometer right and left for every patient. So there may be multiple agendas to it. I'm not sure, but not necessary. So yeah, so what is the evidence for prone? Like I said, even though we have some sort of evidence to say that prone increases saturation, even I have collected some data suggesting that from pre-proning to post-proning, after 5 minutes, on an average, there is a 4-point value increase in the saturation, and there is some reduction in the heart rate, and there is some reduction in the respiratory rate for people after 5 minutes of proning. So we have some data in hand, and we have some data which has been published in the form of observation study or case series suggesting prone may help. Again, it is not a solid evidence, but yes, with the pandemic situation, which is fair enough for us to go ahead with the prone positioning. And we do have some biological reasoning for that. So as you all know, it increases the transpulmonary pressure, or the homogeneous recruitment of the alveoli is better in prone position rather than in supine position. So with that theoretical understanding, proning with some published favor towards prone, I think we can prescribe prone, or if it is already being prescribed, I think you can re-emphasize proning. So every time you finish your other breathing exercise or any mobility exercise, you can put them back in the prone position safely. If that is not possible, you can put them in any one lateral position. And like the recommendation, as you can I mean, it's not here. The recommendation from the Ministry of Health is 16 hours in a day. Somewhere you can maintain one position between 30 minutes to 2 hours. So after 2 hours, you can come to a side position, right or left, and you can again after 2 hours change to other position. So you can keep changing the position for every 2 hours, and not necessarily like you have to maintain 2 hours. So when and ever patient feels any discomfort, they can change the position. And to prevent those discomfort, you can use some adequate pillows to make them comfort in the position. So the recommendation is use a pillow one to the neck and the chest, which is extending to the ASIS, and one below the shin. So this will help to increase the comfort level and reduce the pressure areas, by which the complaints to the prone position will increase. So proning we can emphasize. And coming to the role in severe and critical category, why we have to be a part of ICU in COVID-19 patients. So in management of hypoxic, there is very limited role, because the classification of moderate to critical is in terms of oxygen cannot be satisfied by physiotherapy interventions alone. So it need lot of other interventions when it comes to ICU. Say it could be a steroid, and I mean the right administration of steroids and using of oxygen with a lot of other different delivery devices, because in ward mostly it's nasal cannula or the Hudson mask, but in ICU it is different. So it can be a high flow nasal cannula, it can be a NIV, or it can be a Venturi mask, or it can be NRBM, so non-rebreather mask. So any of these things which can deliver low to high flow oxygen needed for these patients, along with other medical management. So what are we going to do for these patients in terms of hypoxia? I think we nil intervention for COVID-related lung damage. Nothing much can be done, except we can encourage the patient to go on prone as early as possible, as often as possible. So what the literature is suggesting, if we encourage proning in the earlier stage of disease, um, or before the lung damage has happened more, there is a chance that the de-recruitment will not happen. So the recruitment will be maintained in the early phase of the disease. But remember, we cannot prevent the progression. To an extent, we can prevent the lung from going atelectasis stage by proning the patient in the early phase. So we can be a part of ICU team, because most of the time it's become difficult to handle the patient alone. So we can be a part of team in proning the patient in any type of mask, because literature is saying you can prone the patient with HFNC, you can prone the patient with NRBM mask, or even with NIV, or mechanically ventilated or invasive mechanical ventilation, we can prone the patient. But except for the fact, for the invasive, the patient will be sedated and paralyzed. But for other categories, the patient can be awake. But remember, with NIV, it gets so difficult for the patients to prone. So in my setting, or in whatever uh, uh, work experience I had with the COVID in the last almost 8 months, I could never prone the patient who are in NIV. Maybe I could try semi-prone or a lateral position, that I could do, but never I could achieve a complete prone, because what they're suggesting, they have this NIV helmet that is more comfortable to go for prone. But most of our settings will have a different mask, which is very, very tight fitting and constantly blowing air in the face, which gets difficult to cooperate with the machine from the patient side. So all I could do is prone the patient who are in HFNC, NRBM mask, but never I could do NIV. With invasive mechanical ventilation, yes, we could prone. In the last 8 months, say some 3 to 4 patients, we did prone positioning. But again, it is a very laborious process to prone the patient who are mechanically ventilated or invasive mechanical ventilation. So having said that, okay, so what else we can do? Thing is, it is not just the lung which is, or the respiratory system which is damaging once they are in the ICU. With the given medicine, and with the given time of length of stay in the ICU, and the period of immobilization, and the disease progress per se, everything contributes, or everything affects multiple systems. So um, one of the common side effect being in ICU is people getting ICU acquired muscle weakness. Okay, and this affects 25 to 50% of critically ill patients, which is a huge number. So it's like almost 3% to 5% in 10 patients are getting affected with ICU acquired weakness. There are other terms as well: critical illness induced polyneuropathy or myopathy. So that there are various physiological reasoning behind that. We are not going to that, but this is one of the common condition patient land up in if they are admitted in critical ICU, particularly when the stay in the or the length of stay in the ICU is somewhere between 7 days and more than 7 days. So, and again, why we have to intervene in ICU is it has been found out that there is muscle wasting and loss of muscle strength occurring as early as 10 days, even with mobility and the respiratory functions. Even with the interventions like mobility and the respiratory measures, what they could find out that it just plummeted down to, or it exponentially deteriorated compared to other diseases where you could see muscle wasting. So, what percentage of this muscle mass happens for different kind of patients is for people with multi-organ failure, almost like 100% muscle loss. So this is one of the reason why you see elevated creatine kinase level in the people with critical ill patients. If you have happened to read the biochemical chart on a daily basis, you will happen to see progressively you see there is elevation of creatine kinase. One of the reasons for this is the people lose their muscle, and which contributes to the elevation of CK in their blood. So, and more than 7 days, almost 80% of patients who are in 7 days of mechanical ventilation, there will be a muscle mass loss, and who, I mean, even if they are in 3 days, there is at least 33% of people landing up in reduction in the muscle mass. So what can be done to prevent this, or at least not prevent, but to how to manage this ICU acquired weakness? How to prevent people from losing muscle mass, or how to maintain the strength or to an extent? So three roles, two roles more importantly. We can be a part of positioning and repositioning. And as you all know, why we do that. So positioning in the prone or right or left lateral. In one way, it helps the patient to utilize the recruitment of the lung in a more homogeneous way. And it also helps the patients to relieve pressure prone areas. So prophylactic pressure sore measures is achieved by positioning and repositioning, which is almost done manually by a physiotherapist or a nurse over there, or with the help of a nurse and physiotherapist who are a part of positioning and repositioning, with the help of pillows. Sometimes it is passive, sometimes it is actively done with the help of pillows placed. And early mobilization, we'll talk more on early mobilization, what it is and what I mean by early mobilization. And manual techniques, not often necessary. So many of you must have noticed it is being propagated in televisions, in news, and many other social medias. People do clapping and percussion and vibration for COVID-19 patients who are in ICU, or for that matter, any COVID-19 patients, which is not often necessary. And again, uh, even if you try to understand from the physiological point of view, it didn't make any sense to say that, okay, even if there is no evidence to support manual techniques like percussion, even biologically, it didn't support us. So I I almost refrain from giving percussion or vibration from most of my patients, unless they have a copious secretions, or if they are ventilated for longer period of time, where we know that almost for all the ventilated patients they have this problem in the self clearance, because it is they are intubated, but still the process of secretion is continuous. So there is a necessity to clear the secretion. So one way of doing it, we put frequent suctioning or 4-hour suctioning if necessary, or 6 hours, or if there is any obvious sign of obstruction in the ET tube. So if there is a copious amount of secretions coming out of the ET tube, and there is an obvious sign of exudative pneumonia along with the viral pneumonia, which is a kind of secondary infection after viral pneumonia, that again not happens with everyone, but people who are comorbid, like COPD or a bronchitis patient or bronchiectasis patients. So those kind of patients who are at risk of developing secondary bacterial infection, where it manifests as exudative pneumonia. Here in viral pneumonia, it is not exudative mostly. The autopsies are suggesting it is not as exudative as a bacterial pneumonia. So it is the alveolar damage. There are some lymphocytic infiltration and other things like that. But more importantly, it is a formation of hyaline membrane, which is blocking the diffusion of oxygen and carbon dioxide rather than the fillage of alveoli in the form of exudation. So if there is no exudation, if there is no secretion coming as a part of disease, I don't find any reason to give percussion as a regular protocol in managing COVID-19 severe patients. So I make a point that only if there is a absolute necessity where they have some secondary complication and a lot of exudative pneumonic changes, and if there is a copious secretion where they cannot actively bring it out, say for example if they are sedated or paralyzed, and if they are weak enough to 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 um, uh, to cough effectively. So in only those times I go ahead with percussion and assisted cough to an extent. Remember, even even in pneumonia, okay, let's keep the COVID aside. Even in pneumonia, this is a Cochrane systematic review. Pneumonia, bacterial pneumonia, most of the time, where it is mostly exudative pathophysiology. Even for those pneumonia, chest physiotherapy might not be recommended as a routine part of management in ICU. So this is not just me telling. This is the conclusion from the systematic review published in 2013. There are some drawback in this, like only few RCTs were found, like 4 to 5, and some of the RCTs were very old, but still it makes some sense for me. And it didn't help them in so many parameters like mortality or length of stay. So even for bacterial pneumonia, it is not recommended as a routine. So if it's not for bacterial pneumonia, and then I don't find the reason why it has to be a regular protocol for a COVID-19. So where we know that the pathophysiology, it's not exudative most of the time. It is just parenchymal damage along with alveolar damage, very limited exudative process happening. So only two things I do mostly is I position the patient, and I, after screening, if they fit into my early mobilization protocol, we have some safety criteria for that. So we start doing early mobilization. And so why early mobilization? Again, it appears to decrease the incidence of ICU acquired weakness, improve the functional capacity. So there are some outcome measures which are specific to ICU, like functional status score ICU, functional mobility, or ICU mobility scale. So in those aspects, in those terms, the early mobility seems to have some impact. I'm not saying it is the wonderful treatment for people in ICU, because if you go and see the recommendation, it is not a stronger recommendation. It is a very weak recommendation. But still, I sincerely believe and hope that it will have a significant impact in the activity level, and to an extent to the participation level. Even though at present we don't have a much stronger recommendation to recommend early mobility for the people in COVID-19. We have evidence to say that early mobility in ARDS and other SARS patients, it made impact in terms of length of stay in ICU, but not in terms of mortality, but length of stay in ICU. Just 1 second. Sir, இருக்கீங்களா சார்? ஹரிம் சார்?
Yes.
இல்ல, the நடுவுல ஸ்டாப் ஆயிடுச்சு. I'm not sure if the YouTube is streaming live or not.
It is. Sir, Prakash is there, so I think you can just.
Okay, sir. So let me know if it is not streaming. Right. So we know that it works to some parameters like length of stay, where it reduces the length of stay to a median of 4 days compared to the usual care group. As I don't have to mention, reducing 4 days in ICU is not it's not a joke, because 4 days, if you happen to calculate the amount of money they spend and the amount of stress they have to spend in ICU, 4 days, I think it's a lot of change, which I think it's a clinically important measure as well. So this is for you to understand, okay, for who I have to select the early mobilization and what are the safety criteria I have to check before I touch the patient, or before I mobilize the patient, or before I make the patient actively involved in the exercise. So remember, in ICU, it is the vital parameters which has to be constantly monitored. So we also have to keep our eye constantly on that. So all our safety criteria depend on these vital parameters. So if there is a cardiovascular instability, or if the patient is in high dose of life-saving drugs like adrenaline, noradrenaline, vasopressors, or inotropes, remember, do not touch the patient. Or if the patient is having high need of FiO2, the critical cutoff is 60%. If the patient is in 100% FiO2, and if
Sir, can you go slower? This is very fast. It's difficult to follow you.
Right, sir, right. If the FiO2 is more than 60, that is a critical cutoff to say, okay, the patient may not benefit from the early mobilization, or more than benefit, the chance of harm effect because of the mobilization will be more if the FiO2 is more than 60. And neurologically, if there is an increased intracranial pressure, or if it is a recent stroke, or if it's a recent myocardial infarction, and if there's some surgery with or if the patient is having any bleeding disorders with platelet count very low, say for example critical cutoff is 20,000, or if the INR is more than 3 or close to 5, because sometimes when the patients are prescribed anticoagulant or warfarin, for some reasons their INR will be maintained in the higher range. So you have to be either stop it, or you have to do it in extreme precaution. So these are some of the parameters for us to see whether to initiate mobilization or not. If you happen to see these things, do not mobilize the patient at that particular day. Maybe you have to screen on a subsequent days. And so if you happen to move through this checklist, you can see, okay, if you have assessed for precaution, and you can move ahead for activity goal. And activity goal, again, you can classify based on a level of assistance. If the patient need maximum assistance, you can just deliver PROM. Or if the patient is sedated and paralyzed in the mechanical ventilator, you can do PROM. And some high setting, there are high sophisticated machines like passive bedside cycling is available, passive transfers, which are very limited in our resource. So what we do for the people with maximum assistance, or the people who are sedated, or the people who are paralyzed, we do PROM, and we position the patient every 2 hours. So that is a maximum we can do for the people with sedation and paralyzed patient. Only if there is a sign of secondary infection with copious secretion, or if the patient is ventilated for longer period of time, where we know along with viral changes, they may also land up in something called VAP, what we call ventilator associated pneumonia, or hospital acquired pneumonia, where it is all a chance of secretions more, and the chance of mucus plugging is more. So you can deliver a manual technique as a part of regular treatment for these patients, but not daily or not for everyone. So you have to take it as a case-by-case approach. And people who are moderate assistance, when they need 25 to 50% of external assistance, we can start with active resistance or active assisted, and some bed mobility exercises as a form of isolated movements, as we all know, like heel slide or ankle toe movements, shoulder flexion exercise. Any form of bed mobility is fine. You can just involve the patient in moving the joint. Doesn't matter in which direction or in which sequence. All you have to do is just ask the patient to move. Minimum assistance, like 25% and lesser, Now I think it is safer to transfer the patient from supine to sit, edge of bed. And if the patient tolerates a sitting without any uh, uh, without any dangerous change in the vital parameter, I think then we can safely move the patient out of bed. So you can make the patient sit in the chair, or if possible, we can even ambulate the patient. But in COVID, it becomes very difficult to ambulate the patient because they are in continuous need of oxygen, or continuous need of high flow oxygen, which limits uh, the ambulation part of the protocol. But otherwise, you can make the patient something called standing march past, where they have to alternately lift the legs and connected with the oxygen, so you don't have to disconnect it. And you can make the patient sit in the chair for 20 minutes. That's what I do, because that's how the usual guideline is. So I make the patient sit in the chair for 20 minutes. More importantly, you have to monitor the saturation level, the heart rate level, and the respiratory rate level. If there is any deviation, I'll tell you what deviation is dangerous. So you have to put patient back to the supine position again, or prone position if possible. So these are the safety criteria to be looked for. And this is one of the patient which I have attended. So he's mobilized out of bed, sitting in the chair, as you can see here. If you can look closely, his saturation level is 90%. His baseline was again 92, 93 in the prone position. So when I made him sit, there is some desaturation happening, but not to a significant level. So you can bring the chair close to the bedside where the oxygen is connected. So on that particular side, along with the oxygen, we can make the patient sit on the edge of the, sit on the chair for 20 minutes. So there are more reasons to do it. There are many basic science studies done to find out whether the position have any impact on the respiratory parameters, and it does. So healthy patients, and even patients with lung and other neuromuscular diseases, they found out that most of the respiratory parameter, like forced expiratory volume in 1 second, peak inspiratory maximum, or peak expiratory flow, were higher in more erect position rather than lying position. As you can imagine, one of the most easily understanding or theoretical understanding is in supine position, there is a compression of the abdominal contents and the movement of diaphragm more cephalic than caudal, which all reduces the vital capacity of the lung. In terms, there is a reduction in the FEV1 or any of these parameters. So one biological reason why it is all better in erect position is the lung gets more space, because the abdominal organs goes down, the diaphragm is pulled down, so there is more space for the lungs, because we know that the law of the pressure, it's directly proportional to the volume. So if there is more volume, we can generate more pressure. Why we need to generate more pressure? The cough reflex, or for a better effective cough, we know that we need to have a peak expiratory flow of at least 160 liters per minute. So what they have found out, all these values are better in upright erect position. So even if you suspect secretion, and if you want to encourage patient to be actively involved in the clearance of the secretion, so when you mobilizing the patient for upright position, you can actively make the patient do the cough or huff along with the early mobilization, by which we can combine the early mobilization with respiratory therapy, not passively but by actively. Again, I am not telling when to give passive, because that is have to be taken on a case by case basis. You can go ahead, do passive when the cough effort is weaker, even in sitting, or they are very fatigued to generate sufficient force to cough. So in those times, you can go and do the cough assist technique, or if you want, you can just do some gentle percussion to help them clear the secretions in sitting position. Doesn't matter. So you can do that as well. And so this is again why we have to put the patient in the erect position once in a while in critical illness. So again, this is another uh, literature suggesting if the patient are involved in early mobility, the respiratory parameter and functional activities are not deteriorating as when compared to the usual care. So if you can see here, during admission to discharge, there is a difference here. So people who are involved in the early mobility, the respiratory and peripheral muscle strength and functionality are preserved. So even at the impairment level, we know that it helps. So this is one of the important thing to remember. Even if you're not doing any good for the patients, I always make sure that, okay, let's not do any harm because the cost of harm is not so easy, both in terms of money or in terms of physical distress. So you have to be very careful because what we know for sure, or the benefit from physiotherapy treatment, is very, very iffy or not so certain. But understanding the adverse event will help us to prevent any untoward event for which the costs are very significant. So these are the common adverse events we encounter. Orthostatic hypotension, which doesn't need much explanation, but still it is defined as fall in BP when we make the patient sit or stand. So the definition is fall in 20 mmHg in systolic or fall in 10 mmHg in diastolic is considered to be a orthostatic hypotension. So if we are trying to move the patient for the very first time after a longer stay in the bed, the first thing to do is take the BP in the lying, take the BP in the sitting, and take the BP in standing, and find out if there is any significant drop in the pressure to be considered as orthostatic hypotension. You can also clinically ask the patient if they have any symptoms like blackout or any dizziness when they come to the upright position, which most of the patients do complain. But the point is, for many patients, it is very transient. So you can wait for the system to adapt. But if it's so severe, the patient couldn't tolerate the position, then I think you have to put the patient back to the supine position. And then again, we have to slowly come to the erect position by gradual inclination of the head end, or you can do some bed exercise like isometric exercise of lower limb, where the most of the venous return is helping by the contraction of the calf muscles and the isometric quadriceps and the adductors isometric. So these are some of the maneuvers which can help the blood to return to the heart. And again, adequate hydration can be looked for. So you can always find out from the chart if there is a adequate input and output. So that if there is a negative fluid balance or a positive fluid balance, so find out if there is adequate fluid has been taken. If not, you can consult with the intensivist saying that there is a fall in the pressure. And as I can see, I think the hydration is a problem of or a causative factor for hypotension. So I think we can hydrate the patient enough to reattempt the vertical orientation. So those kind of decisions can be taken if the patient is symptomatically hypotension. You can also look for tachycardic status. Say, for example, from the baseline heart rate, if it goes more than 20 or 30 values, then it is a classical sign of orthostatic hypotension. So if you're not able to measure the BP for some reason, but if you could take the heart rate with the help of pulse oximeter, just put it in the finger and find out from supine to sitting, sitting to standing, if the heart rate from the baseline is more than 20 or 30. 20 to 30, I think it's okay to wait for, but if it's more than 30, I think it's definitely patient is going for a fall in blood pressure because the cardiovascular system is trying to accommodate or adjust. So put the patient back onto the supine lying before you find out what could be the cause. So that is one adverse event we have to be vigilant for. Exertional dyspnea, again, which is a very common manifestation for most of the viral pneumonia, or for any patient who have spent quite a time in the ICU. Like I said, because there are many systems which are being disturbed. So there is a muscle mass loss in even after 3 days, and there is a strength reduction. So the hand grip, what they found out, hand grip strength reduction is less, and there is a isometric torque in the quadriceps is less. So, and again, we know that cardiorespiratory reserve is also been affected. So whenever the patient start to do any activity, the patient respiratory rate will increase from the baseline. So the point is, if the patient respiratory rate goes above 40, then, or if it is more dyspneic or laborious than the baseline or the before the activity, I think you have to stop doing what you're doing. And what are the other ways of looking at exertional dyspnea? You can ask the patient, or you can show the Borg dyspnea scale, modified Borg. You can ask the patient in what level they are experiencing the dyspnea. If the patient is so collaborative, you can use this, but most of the time it is very difficult because the comprehending the scale needs little time. But otherwise, in terms of parameters which is available in the monitor, or you could just see the patient, the rising of the chest. If it is more than 40, then I think you have to stop what you're doing. And the other common adverse events, which is peculiar for COVID-19, is exertional desaturation. Because we know that there is extensive lung damage happens. So whenever we start to move the patient or demand from the respiratory reserve, it is not enough. So there is a desaturation from the baseline. So what is the dangerous level, or when to classify it as an exertional desaturation? If there is a drop in 4-point value, then it is exertional desaturation. Say, for example, the patient is a 94% SpO2, and when you start doing activity, it is now 88 or 90, then it is exertional desaturation. You have to stop doing what you're doing, and you have to take the rectifying measures. So rectifying measure, one of the easiest thing what I do is, if you happen to see desaturation, or if you know the patient will desaturate because it happened previously, you can proactively increase the level of oxygen from the baseline to 2 liters to 4 liters based on the severity level. But let me tell you, if the patient is already on the maximum flow, say for example 15 liters in the O2 meter, or is already in HFNC or in the NIV, then I don't think we can escalate the oxygen now. So I think we have to stop the treatment and screen or attend the patient in a later time. But if the patient is somewhere in the moderate need, like 10 liters or 5 liters, and you expect a desaturation, then you increase proactively 2 or 4 liters from the baseline to a higher level, and then you mobilize the patient. So the desaturation will be tackled or will be prevented to an extent by increasing the oxygen. And again, the other classical adverse events which I see in significant number is platypnea orthorexia. What we call platypnea orthorexia is when we make the patient sit from supine, that the saturation drops immediately within a seconds. This used to be a common manifestation in cardiac patient for whom there is a right to left shunt. The platypnea orthorexia is a classical feature for those kind of cardiac condition where there is a intracardiac shunt from right to left. But here in COVID, we see a lot of this kind of manifestation where the patient could not tolerate the vertical orientation from the supine. So just the change of position from supine to sitting itself will cause desaturation. There are so many theories. I'll just show you one theory why it is happening. But you have to keep in mind there is a chance of desaturation just making the patient sitting, not doing any activity per se, but just by making them sit or putting the patient to erect position will lead to a desaturation. Not to a 4-point value or 10-point value. Let me tell you, I have experienced severe desaturation. The patient will be 94, and the moment I make the patient sit, it will desaturate even up to 70 or 65%, which is a very, very severe hypoxic, which is not a favorable condition for us or a favorable scenario for us to witness in the ICU. So if you know the patient is not tolerable to sitting, the next day what you can do again, like I said, for that you can slowly.
Sir? I think it's getting late, so can you just summarize so that
yes,
we have a lot of Q&A,
finishing.
so that
Right, yeah.
Probably say those things in the Q&A.
Yeah, I'm almost done, sir. I'm almost done.
Yeah.
So you proactively increase oxygen to see if it is slightly prevented. And the other important adverse event is fall. We know that patient have a significant fatigueness and weakness after admission in the ICU. So there is a risk of fall. So it has to be prevented by whatever measures you can, like need of assistance or other proactive measures, like if you have a harness and things like that, you can use it. So these are some of the adverse events during physiotherapy which needs to be prevented. So this is again how the system is compensating for mild to moderate hypoxemia. You can see the cardiovascular system is trying to adjust by increase the heart rate. So people with severe hypoxemia, you can see that the heart rate is mostly they'll be in tachycardic, and they will have very, very poor tolerance to exertion. So this is the correlation between the hypoxemic and the exertion, or the tolerance to exertion. So this is one of the theoretical understanding for positional change. So there is a lot of intrapulmonary shunting happens, and the other reason is decreased venous return, which all contribute to the alveolar hyperventilation and desaturation for during sitting. And so it doesn't end in the ICU. So our main aim is to move the patient from the ICU to the ward and community as early as possible. So what are the common problems people had in a long term? So this is one of the follow-up study in 3 months where people found out that the fatigue was still persistent even after 3 months. So 95% of people who had fatigue as a symptom initially, 87% of the people still had a fatigue even after 3 months. So as you can see here, fatigue, dyspnea, chest tightness, cough. So these are some of the symptoms pertaining to scope of physiotherapy, which we can try to intervene and help the patient. So these are the common manifestation even at 3 months. So post-COVID, there is no set protocol to say, but the mantra or the best possible way to address the problem in the post-COVID is little and often, because we know that patient will desaturate, patient have a lot of fatigue in the body, so it's very difficult for us to sustain the activity. So you can break the activity as little as possible, as often as possible, and I think that helps the patient to recover. And most importantly, you have to remember that the disease will take its own time to recover. So it is taking a lot of time to the lung to get better. And what they found out previously in the ARDS survivors, even after 5 years, the return to work or the functional ability is not fully accomplished. So there is some sort of physical deficit even after 5 years. So some damages are permanent, which will take time to either compensate or to even get compensate or even to recover. It takes some time, so you have to give time. So until that, the recommendation is you can make the patient involved in the activities which are light to moderate, in terms of MET, anywhere between 1.6 to 6 MET. The activity involves in this, you can just Google it out contextually. You can choose any activity within this MET. It can be a recreational activity, or it can be a isolated physical activity, or it can be a repeated cyclical activity like brisk walking or cycle within this MET. So anything within this moderate thing you can prescribe the patient, and if they feel discomfort or if they're desaturating, stop doing what you're doing, give some rest, and then again start. So this is what they call pacing the activity. So there is some structured way of doing it, so you can look into it. And the other important thing I have to mention, once you're in the ICU, there is a risk of you getting infected also. So donning and doffing is important, and you have to understand some of the oxygen devices which we use in the ICU have different sorts of aerosol generating risk. Say like here, what they have proven is in nasal cannula, the aerosol can reach up to 16 inch. So in simple mask, again 16 inch. In NRBM, it is 4 inch. So the point is, any device, there is a chance of aerosol generating. So you have to be careful when you are near to the patient, particularly when you're so close in front of the patient, because in 6 feet, that is fairly less a dangerous area for you to work with. But the moment you go so close, when you want to mobilize the patient who needs a lot of assistance, you remember there are a lot of aerosol around the patient, and with HFNC again, or with the nebulizer, so it is a high risk place. So you have to keep in mind that's a high risk zone for us to work with. So again, one way of preventing that is, if possible, just a mask you can make the patient wear with the nasal cannula, which will prevent this aerosol generating flow to a significant level. But it is not possible for people who are in a face mask or NRB mask. But with the nasal cannula, you can just ask the patient to wear a mask, and which reduces that. So just for the curiosity, this is how the X-ray looks, very bad. So you can see it's a bilateral opacity, which is in CT what they call here, all these white things are ground glaze opacity. So the damage is real, and the damage is so extensive for the people with moderate and severe patient, which gets really long time for the recovery to happen. And I'm not sure if I have covered everything you are expecting, but I just want to give the glimpse of what I've been doing and the experience of what I've the last 8 months. So I think the session is open for the questions. If you want to share something, I think we'll have it.
Thank you, sir. I think it's been it was well, I don't have any clue in cardio, but I understood not. So I think it's a good job in that sense. So we will be open for a question. If people are not asking questions, I think I can ask a lot of questions. So
Sure.
I will start with the first question you have already got. It's from Sumanpreet Kaur. I'm assuming I'm saying this properly. Should manual treatment manuals be used in pyretic patients?
Right. So I'm not sure what he means by manual treatment. So manual treatment, if it's going to be percussion or vibration, I think you can do it. If you think the patient is really weak, and if he's not able to actively clear the secretion, and you go ahead, you want to do the percussion and help him to clear the airway, even if he's pyrexic, you can go ahead and do it. Because why pyrexia?
Sorry, sir, I have muted you. Can you unmute yourself?
Do you have to repeat from the first, sir?
Probably the last part.
Okay, so the pyrexic is a concern when we demand from the system. So when you want to mobilize the patient, I think that is where we have to be really careful, because we don't want to increase the metabolism by making the patient actively involved in the rehabilitation. But when you want to give something passively, I don't think that's a huge problem. So if it is really indicated, and if you think the patient will be benefited from the chest percussion or a cough assist technique, I think pyrexia is not the contraindication. You can safely go ahead and do it.
But there should be there should be a classical
need of
need for that.
Need for
right?
that, yes.
Sure.
Because like I first said.
Right. So the next question is from again Sindel, who asked, "What is the difficulty you felt during handling a patient?" I think that's a good question. We have already discussed about that in our earlier.
Yes. Difficulties.
Yeah.
I think that for that we have to do a separate session, because difficulties.
Can you just give us an overview of what are the common?
No, difficulties for me, it happened in different layers, right from coming back to home and managing the patient in the ICU. So I don't know which difficulty I have to say. Okay, anyway, let me just talk about the difficulty in handling the patient. So one thing, when handling the patient, many patients, they are distressed, or physically and emotionally, and it gets very, very difficult for us to actively make the patient involved in the rehab. And let me tell you, some patients even enjoyed the manual percussion. So when I go the next day, they in fact demand to give the mudula tati udunga sir abdina. I do it for no good reason, but okay, I have to gain the trust of the patient, so I just deliver it gently. But otherwise, it's very difficult to people who are connected with NIV, because NIV is one device where there is a constant blow of air in the face of the patient, which is not so comforting, because if the air is leaking, it touches your eye, and the eye gets dry easily, and the constant pressure will make you thirst, will make your lips dry. So even if you're hydrated well, the very fact that your lips is dry will make you think like you want to drink water. So they are in always constant need of water. So the moment the NIV is removed, the first thing they ask to me or to nurse is to give them water. So handling the patient who are in a continuous NIV or patient in NIV, it's very difficult to make them position to one side, or because the parameters will be stable, so they are more eligible to actively involved in the rehab, and their FAOT is not critical range. Everything is fine, but the moment I go and ask the patient, you need to move your leg, you need to move your joints to not deteriorate in the functional aspects, they think it is necessary to take rest when they are unwell. So I think the problem is not just in the physical fatigueness. It is also in our culture and system or belief system, where people assume that when one is sick, they are supposed to take bed rest. So breaking that notion to make them understand to actively participate even in ICU is critical. I think that part is very tough. And for me personally, what I had difficulty is seeing or witnessing a lot of death in a large volume. So whenever I go inside the ICU, I see a lot of body bags and some crashing right in front of me. And for some patients, I was a part of people. I was a part of team in delivering CPR. So witnessing that volume of death and people suffering in a more serious way, I think handling it emotionally, and at the same time not to intervene that in my function or in my work, that was difficult for me personally. And the other difficult, like coming back to home, I have to sanitize so that I don't want to put my parents at risk. So these are some difficult for me in different layers.
Right.
But yes.
So Manimali, do you want to ask a question? You raise your hand. You can open your mic and ask.
Sir, yes, good evening. Thank you for your sessions. Really is good. And one more thing, sir. On next month, I'm going to post it in COVID care center, sir. So that's why I attend this session. So give some suggestion to what we have to do there. I think it's a silly question, but it's a new thing for me.
No, I mean, I think
because I already worked in ICU, but this is the first time I'm going to expose. So because patients are more over there, so that's why I asked you.
No, I think that's what we have discussed so far. In ICU, I think it's more of maintaining the or prevent the patient from decondition in a more severe way. So we help them to actively move the muscles or actively move the joint. And again, let me tell you, by doing this, it also helps the patients to maintain their respiratory strength, because we know that mobilization will also maintain the respiratory parameters in so many aspects. So if you want to maintain the respiratory reserve, as well as prevent the patient from going severe functional dependence, do make the patient actively involved in rehab in any form. Common, or what the protocol or what they mean by early mobilization is bed mobility exercise, which can be safely progressed to making the patient sit independently in the edge of bed, progress to make the patient sit independently in the chair, and make the patient ambulate. So these are the activity which the patients actively participate. So it is just, you can come up with your own idea in making the patient actively participate. It can be isolated exercise or it can be a functional exercise. It doesn't matter. All it needs is move the joint actively at the very earliest time.
Senthil from Nimans, you raised your hand, so go ahead.
Yeah, Ms. Saravanan.
Thank you, sir.
It was highly informative. I just want to add my experience recently, what I had in the ICU. I found very difficult to go inside with that face shield, and the moment I entered, there is no AC actually. Okay, so nothing could be seen, full fog only in the shield. The first day, somehow I managed and came out quickly. I couldn't do anything, any work inside. Okay. And as you correctly suggested, we also somewhat follow in the similar line. He positioned the patient there, either lateral side like that. And in Nimans, it is peculiar. We get all neurological cases, not the typical COVID cases. Those who are admitted there, they become positive and they'll be shifted to the COVID ICU.
Exactly.
So we follow the regular neurological treatment instantly, and chest physiotherapy, as you said, it's very much limited.
Right.
Only certain cases we do have a GBS, transverse myelitis with COVID. So for them, if they show any secretion as such, then I ask the staff to pull suction and then deliver some manual techniques, otherwise links. And and I have some question. In general, we do hear from various sources, from friends and other people, that my patient was in the ward, he was doing well, he went to bathroom and suddenly collapsed like that. What could be the reason?
The one reason, I'm not sure, sir, because in how many incidents like that happened, because for us it never happened. But what we can speculate is his probably blood pressure dropped to, because we know that people in COVID, they spend a lot of time in bed rest. So if he's in any medication which could potentially lower the blood pressure, like antihypertensives, or if he was in any drug for the sleep, so if it was during the night time when the medication was, the activity time of the medication was high. So I think if you look at in the multiple dimensions, the reason for the fall is many things. So it could be because of drugs, or it could be just a decondition of the system where it couldn't adjust for the vertical orientation. Because the fall because of desaturation is very rare. They don't hypoxemic.
Sorry, sir, but I think I remember reading somewhere that a lot of patients die in the early morning, 3 o'clock to something like that, because they had MMC, they had a sort of intensive monitoring during that time. I'm not sure what is the reason, but I think what Senthil is saying has some...
I suspect some pulmonary embolism, because
that could
they
be the
have
reason.
the clotting. Yeah.
Sorry.
That can be.
But anyway, I think that's getting more and more technical. So we will. Joel, can you ask a question? Thank you, Senthil. I'm sorry, we have to get everybody involved. Right?
Sure.
Sir, thank you very much. And Saravanan, sir, that was a good session of yours.
Thank you.
And sir, I have just few questions. I'll just make it fast.
Sure.
When to mobilize the patient, and what is the ventilator setting? Whether we can mobilize the patient on, say, SIMV or only on CPAP, and when we have to mobilize the patient, sir? Do you have?
Right. So right. So I screen all the patients where in the very first 2 days when they are in the ICU. So within 48 hours, I screen all the patients.
Okay.
So my criteria for mobilizing the patient is the parameters in all terms, cardiorespiratory terms, respiratory terms, ventilatory setting itself. We can safely mobilize the patients who are invasively ventilated. But in our setting, it is very difficult because it needs a lot of team effort to mobilize the patient who are invasively ventilated. So it's very difficult for me to do that. I have never done in our setting, but it is being done and it is recommended. So there is nothing. If it is just a respiratory support from the ventilator, but other parameters are stable, like the MAP is between 60 to 110, and the respiratory rate is not too much. It is well between the normal range, or it is not too elevated. And the heart rate is between 60 to 140. It is not in the critical range. It is just the respiratory support where the patient need some amount of support in the form of SAMV or pressure support, and the FiO2 is not more than 60%. We can move the patient. There is no problem at all.
Yes.
For
sir,
NAD, we can. Yes.
Sir.
Sure, go ahead.
I'll just move on to the next question, sir.
Yeah.
Sir, how much and what is the ideal inotropes? Like, how much inotropes can be, if a patient has like 1 or 2 inotropes, like 2-3 ml per hour, like, can we mobilize the patient, like NORAD and DOPA or NORAD or VAS?
We can mobilize the patient with NORAD, given the dosage is not more or the safe criteria. There is no cutoff like that. In few studies, they have mentioned some cutoff like 4 mg.
Okay.
So you can, less than 4 mg, you can try. But if it is more, like some people, it is 15 or some more than 10. Or if there is a need of 2 or more inotropes, then we don't do it. If it's a single inotrope and the dose is very low, you can. But if there is a need of 1 or 2, I mean more than 2 inotropes, and the dosage is high, adrenaline, noradrenaline, dopamine, I think we are not supposed to move the patient.
Okay, sir. And sir, like, I'll just go on to the next question, sir. How much patient desaturation we can accept, and what is the maximum heart rate we can train? Like, how much maximum heart rate we can train the patient?
Right. How much desaturation we can accept from the baseline? Anywhere 4 point is acceptable. So if it is baseline is 96, 92 is okay, but maintaining above 90 is fine. Okay, it's not a problem. So even when the patient is 100, but desaturated 90 is not acceptable. So you have to look in terms of baseline. So ideally, it should not go more than 4 point value, but 4 to 6, I think, should be okay. But more than that, I think it's a severe fall, which needs to be rectified.
Okay, sir. And sir, I just need to just put a word regarding Sendil sir was telling. These patients, like when they go to the restroom, they just collapse. Like even I have seen 1 or 2 patients regarding this. And these patients generally, I've seen this kind of cases on ILD.
Right.
These ILD patients generally, when they go to the restroom, they desaturate. And since like I was just asking this to my consultant, and they were just telling me 2 things, that when they go to the restroom, they need to just increase their oxygen support generally, because since their post-COVID, their respiratory reserve is very low, they tend to easily desaturate. So what they say is increase the oxygen even while you walk or even while you go to the restroom, because they just do an isometric contraction of your abdomen and the sphincters to push the.
Sorry, Joel, you are cut off.
Yeah, I think he was just mentioning to increase oxygen while walking and during the restroom, by which we can ameliorate the desaturation.
Yes, sir. That's it, sir. Thank you, sir.
Yeah, right. I also think that there are some studies which has also suggested that a lot of people get stroke when they go to the toilet.
Yes.
Especially as they increase the abdominal pressure to evacuate, and if they are in the eastern toilet. I'm not sure whether it's a sort of a proper study, but there are few. Anyway, I think there are a lot of questions on secretions. I think we have already answered, so we are not getting into that. Is there a connection between mobility and bradycardia? How to avoid it? I'm not sure you can avoid it, but anyway, I don't know how to ask the question. So Divya, can you unmute and ask it, because I'm not sure what is the question is.
Where is it?
Hello, sir.
Yeah, go ahead.
Yes, sir. I want to know the connectivity between the mobility and bradycardia because one patient was 67 years old. He had unexplained disease, and the saturation level and pulse rate was very good. Still, I was there monitoring, and she did just mild active range of motion exercises. But after 20 minutes, she developed bradycardia and she felt extremely sick. This was when I was in the ICU. And the next patient was just 37 years old with no comorbidities, post-COVID. He was with the venturi mask, and he was made to sit by the staff nurses. And following the mobility to chair, after 2 or 3 hours, he developed bradycardia and he went extremely sick. And the next day, he passed away with all the multiple organ failure. So I just want to be sure whether it has some connectivity with the mobilities or whether we have to look out for some course and guidelines or something like that.
I'm extremely sorry, ma'am, that I don't have any information on that because I haven't experienced and I haven't even come across literature like that. But I will definitely look into it. But if there is no indication for the patient to go for bradycardia, I think then it's very difficult for us to decide whether to do the mobility or not. But it's very unfortunate that the patient developed bradycardia. And I don't know how it happened, but I'll definitely look into it. And if anyone else have any clue on what it is, you can pitch in and please.
Saranan, I just have another question from the YouTube chat also.
Sure, sir.
How to avoid exertional dyspnea in spite of maximum O2 support? I don't know. Again, I'm not sure whether what they're asking, but that's the question.
How to avoid exertional dyspnea
in spite of maximum O2 support? I'm not sure what it means, but
no. If it is because of exertion, I think you have to reduce the intensity of the exertion. So if it is at rest dyspnea, even after maximum oxygen, I think we just have to escalate the treatment from low flow cannula to either NIV, or we have to go for invasive mechanical ventilation.
2030.
But if it's because of the exertion, I think we have to tone down the exertion, or we have to just involve in a very milder activity. If that is also not possible, maybe we have to come later to find out if the patient tolerates even a milder form of activity. Until that, we have to wait.
That is, exertional dyspnea is part and parcel of
it is expected. Yes, it is expected. Yeah. But with maximum oxygen, if it is not helping, then we have to wait.
Those are the questions. If anybody else has some questions, I'll also throw one or two. If anybody else has a question they want to answer. I think we have covered a lot of technical issues also, I suppose. Can you just re-emphasize what are the sort of physical and psychological measures to safeguard ourselves when you are entering the ICU?
For ourselves, sir?
Yeah. For the PT.
For the PT, yeah. I mean, personally, when I initially started working, it was all alone because not many support from the peer team to pitch into the work. So it was all alone. And like I said before, witnessing a lot of death and handling the physical burden. And it had an impact. But I think what helped me is now we have a team. Like now we have included some PGs and interns to work inside the team. So working as a team, I think it helps. And more importantly, you need someone to open up. Doesn't matter, you just have to talk about what you've experienced, but you have to have someone to just share whatever things you want to share. So having some close friends to discuss what you feel and reflect upon the thoughts and whatever you get, and working as a team will help to reduce your burden, as well as it will it kind of help me have an emotional support, just seeing other person who are working as a part of team. So I think those two are important. One, to work as a team, and other thing is to talk openly with someone who you trust or someone who is so close to you. Physically, I think you just have to eat well, hydrate well, because like Senthil sir mentioned, it's very difficult to, once you wear the PPE. Staying 4 to 5 hours in the PPE is very difficult. You will dehydrate a lot, you sweat a lot. And more importantly, what I personally felt, it's not in the literature, I get tired easily. So at the end of the day, I never used to sleep early, but in the last 6 months, I sleep early. But the problem is, again, I wake up early, or many late nights I had some nightmares, and I used to get up 1 a.m., 3 a.m. Just for no reason. Sometimes my nightmares reflect physiologically, sweating and increase in the heart rate. So those things happens at times, and for which I was prescribed some medicine. I'm not. You can take professional help if at all you want. There is nothing wrong in taking the professional help to balance your mental health and physical health. Yeah, you can just involve in some milder activities, eat well, no junk, just eat well, and maintain your weight. And I think that should be.
And also, I'm assuming proper donning and doffing of the.
That is the first criteria. And I forgot to mention, if you want to step inside ICU, please first get yourself vaccinated. And if you're vaccinated and it's been more than 2 weeks, I think you can consider you are relatively safe, that you will not get COVID, even though we are seeing people are getting infected even after 2 doses, but not to the severe level, only in the mild or asymptomatic. So please do get vaccinated if you ever want to work with a COVID patient who are actively infected. And
no. If you are a medical professional, you have
yes, you have to. It is actually for everyone. But if you have, for any reason, if you are thinking not to take vaccine, please, that is not the sensible thing to do. Get vaccinated if you want to get inside. And second thing, donning and doffing, you have to be meticulous in doing it. So make sure you watch some videos. You have some local institutional team for that who teach on a regular basis how to don and doff, and who are because in many places there is one person appointed just to check whether you are properly donned or not. And there are some flyers in the form of a printout, or there is a board where they have written all the guidelines. So never assume you know the sequence, because even now I check on a daily basis whether I'm doing it correctly or not. So I keep myself at check. I don't get overconfident even though I'm doing it daily. So I check the sequence. Even now I watch some videos how to don and doff, because sometimes in overconfidence we tend to do mistakes. So it's not the mistake we do it early. Most of the time we do make mistakes when we happen to do the same thing for quite a period of time. So I think just don't get overconfident, particularly in terms of donning and doffing. You can be overconfident in other things, but not in donning and doffing. Please maintain every protocol when you're donning and doffing. And other thing, if possible, you can take a shower in the hospital and come back. You can change your scrub to a different dress and you can come back. If that's not feasible or possible, come back home. You take the shower and try to put those scrubs in a separate washing or as a separate form of washing rather than mixing it together. And if you have parents who are old, not vaccinated, comorbidities, try to stay away from them as much as possible, only limited. Even if you want to get close to them, try to have a mask, but otherwise try to stay away from them and be in a safe distance.
Eat well, sleep well, and no swimming in tsunami.
Right.
Right. Okay. I think we have covered a lot. So thank you so much, Anna. This is the first time we have got so much of good feedback, I think. So that's a nice one. And also, I think there are technical details we have also discussed. Anyway, thank you so much for everybody for attending. If you have any queries, please contact Saravana. And I think it's a teamwork. So if you have some ideas, if we all discuss, not me as such, because I don't have anything to say in this. If you all have a better sort of discussion among people who are working in ICU, who are going to ICU, and things like that, we may have, we may come out of this this pandemic in a slightly better shape, I suppose. Saranan, last words?
No, sir.
Be safe.
Yeah, be safe. Because no, one thing is because we know that it is the post-COVID situation. It's not going to leave the patient as easily. So even if you're not going inside ICU, or even if you're not part of an active infected patient, I think you have to be aware of post-COVID sequel to handle the patient more efficiently. So I think even if you're outside or in a private session, running your own clinic or own setup, try to be more aware of the problems in a post-COVID sequel to handle it better. So I think otherwise, just be safe, stay alive for next meet.
Yeah, thank you so much. Yeah, also Nityananda has told us that if you live for
next 3
another
years,
1 year, all going to circum directly. So be safe, people, and have a blast when you're treating, because this is all crushing our soul, all the death and things like that. And we also want to emphasize we don't have much of information on post-COVID. That's why we are not answering any of those questions. Thank you so much. See you some other time. Bye-bye. Better times.
Bye, sir. Thank you. Bye. Yeah.